Good afternoon. Bonjour. Today I'll be sharing the national epidemiology and the modeling work we are using to inform ongoing control of COVID-19 in Canada. But first I'll begin by providing the latest numbers on COVID-19 in Canada. There have now been 106,167 cases reported in Canada to date, including 8,711 deaths. 66% of the cases have now recovered, and labs across Canada have tested over 3,020,000 people for COVID-19 to date. Over the past week, an average of 38,000 people were tested daily, with 1% testing positive. These numbers change quickly and are updated daily in the evenings on canada.ca/coronavirus. Je vais aujourd'hui le point sur les travaux scientifiques.
Today, I'll be sharing the national epidemiology and the modeling work we are using to inform ongoing control of COVID-19 in Canada. But first, I'll begin by providing the latest numbers on COVID-19 in Canada. There have been 106,167 cases reported in Canada to date, including 8,711 deaths. 66% of the cases have now recovered. Labs across Canada have tested over 3,020,000 people for COVID-19 to date. Over the past week, an average of 38,000 people were tested daily, with 1% testing positive. These numbers change quickly and are updated daily in the evenings on canada.ca/coronavirus.
I'll begin with the update on the latest epidemiology of COVID-19 across Canada. Maintenant, diapositive 3.
Slide 3. Although most health regions in Canada have reported cases of COVID-19, this map, showing incidence rates per 100,000 people, illustrates that some jurisdictions and regions within have experienced more activity than others. In particular, Quebec and Ontario have had some heavily affected areas, and considering their larger populations, these jurisdictions account for 87% of cases overall. At the same time, other jurisdictions, including northern Saskatchewan, have reported high case counts relative to their population size. If we look at the boxes to the right and lower box regarding deaths, the proportion of cases who died has remained at about 8%, reflecting the tragic impact on Canada's seniors in long-term care.
4. These graphs showing daily numbers of new cases and deaths illustrate the steady decline in COVID-19 activity since the peak of the epidemic in late April. The small recent increases in cases may be explained by outbreaks and community transmission in Alberta, Ontario, and Quebec. Maintenant, diapositive 5.
Slide 5. We also have been closely monitoring the number of cases who are hospitalized and those in critical care. Monitoring these indicators of severity tells us that our public health measures have been successful in reducing the number of people with severe illness due to COVID-19.
Grave. Moving on to slide 6, another indicator of epidemic control is the effective reproduction number, or RT. This number represents how many people are infected by each new case. In order for the epidemic to die out, RT needs to remain consistently below 1, meaning on average, each new case infects less than one other person. Nationally, the RT for Canada has been mostly below 1 for more than 10 weeks, which is good news. However, in recent weeks, the RT has been fluctuating and has sometimes risen above 1 and also fallen below 1. At this point, with transmission largely under control across the country and with cases low in number, the daily RT is likely to fluctuate dramatically. It remains important for us to closely monitor for new cases and outbreaks that could arise in any part of the country, even in places which might have few or no cases at the moment. Diapositive 7.
Slide 7. Based on Canadian data up to July 2nd, this short-term forecasting shows predicted cases and deaths due to COVID-19 out to July 17th. On the left, the predicted number cases could be in the range of 106,015 to 111,260 by July 17th. On the right, the predicted number of deaths could be in the range of 8,560 to 8,900 by July 17th. The dashed lines show the predicted trajectory, with the blue line representing the number of cases we anticipate. Since modeling is a prediction, the red and green lines represent the upper and lower limits of this estimate, which is based on projections of possible cases from a moment in time, July 2nd, as I mentioned a moment ago. While we get new data every day, if we were to run a projection analysis today, it is unlikely the projection would be significantly different from what you see on this slide, because we would need substantially more and new data for there to be a change in the trend. Instead, what we expect is that the actual number of cases will be somewhere between the red and green lines. We have used the black and red dots to show what has actually occurred up to the most recent data update. You can see that we are well within the predicted trajectory. This slide shows the projection based on a moment in time. Like RT, there are important limitations to these forecasts, as it is difficult to predict national case and death counts, which are now largely driven by localized outbreaks and hotspots of community transmission.
Moving on to slide 8. The current patterns of COVID-19 infection show limited to no transmission in most areas of the country. The efforts and commitment shown by Canadians across the country over the past months have now shown us that we have been able to impact the pandemic, control transmission nationally, and begin the process of entering the next phase of monitoring and preventing a resurgence. However, we must stay alert and strengthen our response in areas where we continue to have cases in the community and where we have experienced new outbreaks. Areas of increased transmission are shown as darker blue areas on the map. Some of these areas are experiencing localized outbreaks, as seen in Alberta and Saskatchewan, while others represent persistent community transmission, as seen in and around Toronto and Montreal. Maintenant, diapositive 9.
Now moving on to slide 9. Since the start of the epidemic in Canada, long-term care and assisted living homes have been hit the hardest, with over 1,000 separate outbreaks accounting for about 20% of confirmed cases and tragically over 80% of all deaths. Congregate living and work settings have also accounted for a significant proportion of outbreaks. As we gradually reopen society and resume activities, we are seeing outbreaks linked to social gatherings, particularly in closed settings with close contacts. For example, funerals and indoor family gatherings.
On to slide 10. Since April, COVID-19 cases have steeply declined in the older population, with the steepest decline seen in those over 80 years of age. This provides some good news that cases are declining among those at risk of the most severe outcomes. Maintenant, diapositive 11.
Slide 11. In younger age groups, overall cases are also decreasing, however at a slower rate, particularly in those between the ages of 20 and 39. In order to, or rather, this needs to continue decreasing at a constant rate. Although severe illness is less common in younger age groups, young adults are not immune to severe outcomes. In addition, transmission in any age group builds a reservoir reservoir for the virus and threatens our ability to maintain epidemic control. We have a collective responsibility to lower infection rates and prevent spread of the virus to populations at higher risk of severe outcomes or settings where an ember could easily spark an outbreak.
Slide 12. In summary, the epidemiology indicates that the transmission is largely under control in Canada, while also showing us that cases can reemerge at any time or place. In today's modeling update, I'll review why we need to continue with critical public health measures to maintain control, stamp out outbreaks, and prevent a widespread resurgence of cases. Models provide a prediction of what could happen under hypothetical scenarios, allowing us to drive our public health actions toward a best possible outcome. Diapositive 13.
Slide 13. Canada is aiming for strong epidemic control over the course of the pandemic, with less than 10% of the population infected overall. Thanks to the commitment of all Canadians who have been following public health advice to protect themselves and others, we are well on our way down the right side of the big first peak. The novel coronavirus has not been eliminated, and we do not have an effective vaccine at this time. As restrictive public health measures are being lifted to minimize the unintended health, social, and economic consequences, we expect to see a resurgence of cases. The key is to keep the number of cases small through ongoing core public health practices. We must be able to rapidly detect and isolate cases and quarantine their contacts in order to limit any resurgences to a small and manageable size.
Slide 14. Our collective hard work means we have had a great impact on controlling the COVID-19 epidemic across the country. As society reopens, we must continue to strengthen our efforts to prevent a rebound. Public health authorities are continuing to build capacity to rapidly detect new cases and outbreaks as quickly as possible so that action can be taken quickly to prevent future spread. The sooner cases can be identified and isolated in the course of the illness, the fewer other people they might infect. Likewise, when most or all of their contacts are identified early and placed into quarantine, fewer are likely to spread the infection to others if they do become ill. We must also stay vigilant for early signs of a possible increase in cases and continue monitoring indicators that can inform us of changes across the country. Diapositive 15. Maintenant,
Slide 15. Now that there are fewer cases of COVID-19, we need to ensure we know how cases were to another case or source that we can identify. The red bars in this graph show those cases with no known source of exposure, and this proportion is a result of our effective public health measures. The more cases that occur where we don't know how they were infected, the harder it will be to prevent a surge in cases.
to slide 16. These dynamic models all tell us that if we relax too much or too soon, the epidemic will most likely rebound with explosive growth as a distinct possibility. Modeling simulations show us that as we lift stay-at-home policies and business and school closures, indicated by the green bar, we risk the epidemic potentially resurging later in the summer and into the fall if we do not strengthen other public health measures to maintain epidemic control. The enhanced public health measures include rapid case detection and timely contact tracing and quarantine to prevent new introductions, control any new chains of transmission in outbreak or community settings. This possibility of significant resurgence is not just hypothetical, as this is exactly what we are already seeing in some other parts of the world. Et finalement, diapositive 17.
And finally, slide 17. Canada has made significant progress to bring the epidemic under control, thanks to the commitment of Canadians maintaining public health practices to protect themselves and others. Across the country, jurisdictions continue to increase social and economic activity with appropriate conditions and controls in place to minimize the spread of the virus. However, the virus has not disappeared, and resurgence can happen at any time in any place. Until there is a vaccine or effective treatment, we need to continue to live with COVID-19 by balancing the risks of spread of COVID-19 with the unintended social and health consequences of restricted public health measures. If you do test positive, consider that the fewer people that you have contact with, the quicker and easier it will be for public health to trace them all down and interrupt chains of transmission to keep the spread of COVID-19 under control. Thank you.
Thank you, Dr. New. We will now open the telephone line to question. For those who wish to ask a question, please press *1 on your phone. Vous pouvez poser vos questions dans l'une des deux langues officielles. For those asking a question in the room, we ask that you make your way over to the freestanding mic. We can start in the room. First question.
Hi, Stephanie Levitz, the Canadian Press. Thank you, Dr. New, for taking the question. I wanted to canvass your thoughts on this ongoing debate about the full-time return to school for kids. There just seems to be a lot of conflicting approaches being relayed out by the provinces, conflicting ideas about what is safe or what isn't safe for kids, and also this tension between the mental and sort of, I guess, growth, emotional or otherwise, of children versus the potential health risk. And so I wonder how you would counsel people to take that all into effect as they're considering, one, how school boards are putting together these plans, and two, what parents are thinking they ought to be doing.
Thank you very much for the question. It is a difficult issue, and as I think many scientists and public health authorities around the world, obviously including ourselves here in Canada, we're constantly looking at what the science shows us, what the evidence of an experience in other countries has indicated may sort of lead us towards what might be the best possible path in terms of, in this case, opening schools. From the science, what we know is that certainly young people, children, are less likely to have more severe consequences if they do get infected with the virus. The other part also, which is still, I think, in play in terms of gathering evidence, is that it also appears that in terms of transmission, young children, at least in some of the studies I've seen, do not appear to be as efficient or effective in terms of transmitting the virus to others. And therefore, that is, I think, at the heart of the debate. What is the sort of the risk tolerance, if you want to call it, in terms of also risk management for school boards at the local level, but also for parents in terms of, quote, letting their kids go back to school. Also indicated numerous times, there are also many other what we call sort of unanticipated consequences. And we know that for kids, going to school is very, very important for their growth and development beyond just, quote, academic sort of acquiring of knowledge. In terms of socialization, et cetera, we recognize their mental health impacts that are also in play. And so certainly we've learned quite a bit, and we're actually at the present time still looking at what the experience has been in some of those provinces, I think notably British Columbia and Quebec, that they did open their schools to a certain degree, sort of in late spring, early summer. And certainly we'll take a careful look at that. And that would, I think, give us further evidence and data that might help inform provinces and local school boards across the country in terms of what they may wish to decide for this coming fall. One of the other things that we certainly were very cognizant of is that there's different types of proposals being put forward. For example, do all kids just go to school full time, or do we stagger classes, have maybe half the kids go one day and half the other? We recognize that anything other than full-time attendance has implications even for the parents, especially if they're working. And so all these factors have to be taken into account. I think at this time there's no easy answer, but certainly based on what Quebec and British Columbia experienced, and certainly from what I've seen, it's been a positive experience for all concerned. The question now is whether they, quote, ramp it up and then sort of more fully open the school boards, schools, classes to kids in the fall. I think bottom line is that in some ways it is a bit of a social experiment, and people need to appreciate that it is a bit of a risk management and risk tolerance. And certainly my understanding is that at the local level, certainly I think there would be probably an option for parents in terms of having their kids go to school. But I think the final decision, I think, is best left to local school boards. As well, the other part we've always talked about is that it also depends on what the local epidemiology is. Certainly how much virus is circulating in the community may also play a factor in terms of how a local school board may decide in terms of to what degree they open up classes for all kids.
Thank you. Follow-up?
Yeah, okay. I want to ask a follow-up based on now we have mandatory mask requirements going in place in a number of cities. Ottawa is now one. I wonder if you could reflect on what public health has learned in the past when you've asked people to take a mandatory health action and how challenging it can be sometimes to make them do it. And I'm thinking of, safe sex education would be an example, vaccination would be an example, and whether, to what extent at the federal level, you're considering any kind of campaign to try and encourage this and what that might look like given your prior experience.
Thank you very much for the question. It's a tough one. I think from a sort of a health promotion perspective, those of us who work in public health recognize that there are many types of what we call healthy behaviors, activities that we would like people to undertake, but we recognize that based on the number of factors, maybe at a population level, but also individually, those are the things that we need to examine as to why people may be hesitant in some ways to take up a certain behavior that certainly, based on the science and evidence, we in public health would think would be a good thing to do. As you mentioned, vaccination, certainly from a public health perspective, I'm a strong advocate for vaccination. It's certainly been shown to be one of the most effective public health tools in terms of eliminating what we call vaccine preventable diseases. But for some reason, in certain communities or certain groups of individuals, there's a hesitancy. And so I think in many ways, doing more behavioral research, we're doing that across the country, will give us clues as to what might be the underlying factors that we need to address to the increased uptake of vaccination. We recognize that it might be a lack of maybe a certain information, but there are other factors in play as well. With respect to the mask, therefore, I would say that as we've mentioned before, Dr. Tam, myself, and I think other public health authorities across the country, certainly from the evidence that we've seen so far, as a sort of as a population health measure, it's a simple, effective measure. It doesn't cost very much. And I think certainly the evidence from around the world shows that it has been shown to decrease the overall transmission of the virus. So it makes sense. But we also recognize there are cultural factors involved. As we've noted historically, in, let's say, countries in the Far East, maybe culturally it's been much more accepted, or at least earlier compared to maybe Western countries in terms of mask wearing anytime you're sick. It shows, I think, also maybe it's a sign of respect to others that you would wear a mask in public. In North America, I think it's actually been quite amazing with, I think, the information and people becoming aware of the benefits. The uptake and the change, I think, in attitudes in terms of mask wearing have been nothing short of incredible in the course of a few short months. However, I think what also needs to be taken into account is that there are many sort of tools in the toolbox, and certainly health promotion, as you mentioned, maybe advertising campaigns, increasing awareness is certainly, I think, ideal in terms of getting the general public to take up what we call healthy behaviors or activities. But the use of what we call regulations or more of a regulatory approach is certainly usually something of a last resort that we would want to undertake. And so I think we're still focusing on the education and hopefully people understanding the benefits to themselves and others to wear maybe face masks in public, especially in situations where they can't maintain that physical distancing of 2 meters. But at some point, depending on local circumstances, again, it's the epidemiology that drives it. I can certainly understand why local officials might want to make it, how you say, large cities, where there's, let's say, a circulating virus in the activity, and it's a much higher population density. It may make more sense to maybe have that type of a regulatory approach as opposed to maybe, let's say, up north in the territories where there's much more wide open spaces. The other example I would also point to in the past, it's interesting, and I think people now take it for granted, is that when people first talked about car seatbelt use, at the beginning we talked about education and saying it saves lives. You automatically put on a car seatbelt, and when you go for a drive. Successful at a certain point, and then certainly I think looking at the risks and benefits, I think at the end of the day, finally I think what's been done across the board is, quote, the regulatory approach. So that's just another example of another, quote, healthy behavior that can save lives, that at the end of the day, based on the uptake and then other factors, that's the way it went for seatbelts. Can't say that's the way it's going to go for face masks, but those are certainly some of the considerations in play. Thank you.
Thank you. Next question, CTV.
Hi, Dr. Molly Thomas, CTV National News. You mentioned that outbreaks are linked to social gatherings, so funerals or, family gatherings. I think about here in Ontario, is our 10-person bubble too big when we look at, messing with those numbers that seem to have held really quite well over the last month since your last projections?
Thank you. It's a good question. I don't think it's a matter of numbers or how many people are in your bubble. I think it's still a matter of people understanding and continue to be, how we call it, sort of vigilant and disciplined, I guess is a word, in terms of undertaking all of the standard and proven public health measures. So I know we keep repeating, the physical distancing, the good hand hygiene, staying home if you're sick, and certainly wearing a mask or face covering in situations where you might not be able to maintain that 2-meter distance. So I don't think it's a matter necessarily of numbers, but I think with the warm weather, businesses starting to open up, people I think going a bit cabin crazy maybe after the long winter we've had. That people I think it's human nature. Some things I think are forgetting. And that's why I think it might be driving some of these local outbreaks. So I think we need to keep underlining the key public health messages and telling people that no, it's not over. And if there's too much of what we call a relapse in terms of those good public health measures, then certainly we'll see more and more of these outbreaks.
Mm-hmm. And you also mentioned that, that rapid case detection and quarantine has to be a part of it. You said that some other countries are doing this well. Who is doing it well? Who is Canada watching? And what can we learn from them?
Certainly, countries that come to mind include South Korea. And I think they did an excellent job at the beginning, obviously, in terms of flattening their curve. And then recently with uptick in cases, I think it's also part of the acceptance of the culture there. My understanding is that when there were a few cases detected in nightclubs and so forth, the fact that I think it was either procedure or protocol, whatever you want to call it, that in the nightclubs, if you entered a nightclub, you had to give all of your contact information upon entry. And that enabled the local authorities to be able to rapidly sort of contact the individuals who might have been exposed and obviously counsel them to go get testing. So I think those are the kinds of things that we're looking for in terms of best practices that we might apply here in Canada. I think overall, we've done an excellent job because we're now in a place in Canada that most of the cases that we're finding are actually linked to a known source. So I think in terms of a classic public health practice, local health authorities are able to, quote, get on top of cases, do the contact tracing, making sure that obviously and managed well, but also that all of the contacts are found and also counseled, put in quarantine, et cetera, and making sure that they're monitored for symptoms as well.
About masks. So now that, indoor spaces are different for us. So if I'm, going to have lunch today, should I be carrying 3 cloth masks in my purse? I mean, do I have to take it off and then that mask is put into a sealed bag and that's it? Or can I keep putting it on throughout? I mean, how does that work now in terms of not spreading any more of this if potentially I had it?
Okay, well, I can't give you sort of all of the sort of possibilities of how you could or should be using face masks in public. I would say that the one thing that we've always been very aware of in public health is that we don't want the use of face masks in public to sort of give that false sense of security, so that if individuals wear face masks, oh, we don't have to worry about physical distancing, good hand hygiene. And the other also big concern is that by wearing a face mask, it's sometimes what people don't realize is that then they start fiddling with the mask and touching their face and so on. That obviously then puts themselves at risk, obviously, in terms of contamination. So I think the most important thing is that there's lots of, I think, videos online, et cetera, in terms of good, I think, face mask etiquette in terms of how you should appropriately put on your face mask, not fiddle with it, maybe adjust sort of the nose piece. And then afterwards, I think if you do take it off, let's say if you go for lunch, I think if you put it in a sort of a bag or a place that you know that is also, I say, clean, and then also maybe use a good hand sanitizer, etc. After your lunch, I think it would be fine to take that mask and put it on. Usually, I think if it's a good cloth mask, I think using good practices, I think it would be good for the day. If you do happen to have 2 or 3, and that's fine, you could obviously use that, but I don't think we need to make people feel guilty that if they only have the one, that that they're not doing the right thing by using that one mask appropriately throughout the day, and then, as they say, at the end of the day, I think appropriately washing it and hopefully maybe having another one for the next day is what you should do. Thank you.
Thank you, Dr. New. We will now turn to the phone operator.
Thank you. Please press star 1 at this time if you have a question. Veuillez s'il vous plaît appuyer sur étoile 1 pour poser une question. La première question est de Vincent Maisonneuve de Radio-Canada. À vous la parole.
Bonjour, merci beaucoup.
Hello, and thank you. I have a question regarding Montreal that has made wearing masks mandatory in public places. With the data that you have on the situation in Quebec, do you believe that more Quebec cities around Montreal or throughout the province should put rules in place to make wearing a mask in public places mandatory? Answer. Thank you for the question. As I explained in English, wearing a mask is an additional public health measure to protect oneself and to protect others against exposure to the virus. If we give enough information, we can encourage people to wear a mask if it's difficult to maintain that 2-meter physical distancing. Now, regarding making wearing a mask mandatory, well, it's an option for local authorities to use. The authorities have to make this decision while looking at their local epidemiology and their own context. In a big city like Montreal, where there's still virus activity, and given the higher density of population in Montreal, if you compare it to Lac-Saint-Jean, where my wife's family is, I think you need to look at the local differences. It's also important to me to talk about the 3 C's. In French, the acronym is BEC. So it means to avoid areas where there is close contact, avoid being too close to people, and avoid closed spaces. These are important principles. It's another tool that local authorities can use in order to decrease risks. It's not up to me to say what the criteria should be for cities around Montreal. I think that this is a decision that the different local authorities need to make. Thank you. Is there a follow-up question? Nope, thank you. Next question, please, operator.
Merci. The next question is from Vic Adapia from CBC News Health Unit. Please go ahead.
Hi there, Dr. New. By now, I'm wondering if you had seen the letter signed by various former public health doctors in which they call for a more balanced approach in dealing with COVID-19 because the overall, in their words, aim to contain COVID-19 is having increasing inequities across the country, and feel that that provinces and the federal government are taking the wrong approach in trying to control the outbreak. Just wondering what your response is to that, if any.
Thank you very much for the question. I've seen that open letter, and I'm not sure if I agree entirely with the way you're reading it. Certainly, the issues that were raised in the letter are certainly issues that have been recognized on a consistent basis by those of us in public health here working in the federal government, as well as provinces and territories. Certainly, I think Dr. Tam, myself, at our multiple press conferences have talked about the fact that there are certain populations, vulnerable populations, including racialized Canadians, individuals in sort of poorer socioeconomic status situations that are more at risk of being exposed to the virus and having also more adverse outcomes, as well as looking at some of the what we call unintended consequences. The fact that there's been surgeries postponed, other chronic diseases, infectious diseases. Certainly, the care and treatment has suffered because of the focus on COVID-19. So that's been well recognized. And behind the scenes, certainly we've worked tirelessly with our counterparts in public health in provinces and territories to both at a strategic level and also, I think, at a very sort of operational and programmatic level, look at activities to actually address that. One of the issues that has come up, and I think getting to the point of inequities, is that we recognize that you don't know how, how severe a situation is if you don't have good data. So the whole issue of getting better data in terms of race and ethnicity has come up, and we've certainly recognized that. I'm not saying it's being solved overnight, but certainly we've made good progress in working with our counterparts in the provinces and territories. People recognize that we need that kind of data to maybe establish a baseline, and then as we move forward in terms of addressing those issues, let's say, be it inequities, that hopefully then we'll also have the data to later show, evaluate dealing with that. So I think overall, what's in the letter by many of these people who are former colleagues of mine, I wouldn't disagree. I think they've or put again into focus the issues that we've always recognized, and we're continuing to work on them. Thank you.
Thank you. Follow-up question, Vic?
No, that's fine. I mean, the one thing that it just strikes me looking at the projections for the fall, where we have the potential of 4 times as many cases as we did in April. They use the language risk-based. I mean, what's your response to that? Because they seem to be suggesting that it isn't necessarily the same risk-based, but rather too sweeping in the attempts to control the outbreak.
No, okay. So risk-based, I think we're talking the same language, and I think we're seeing it play out even now as we've successfully, I think, quote, flattened the curve here in Canada. Certainly, one of the big fears in the spring was that we would overload or sort of overwhelm our healthcare system in terms of having cases that needed to be in the ICUs, and that certainly hasn't happened. So I think, again, big kudos to everyone involved, all Canadians, the sacrifices that have been made to make sure that we didn't have that many infections that obviously had severe consequences as well. And so now we're in the place in terms of this transition where we're now looking at, quote, slowly opening up the economy sectors, and as you also pointed out, in a sort of a risk-based approach. So looking at the epidemiology, I think we're now in the world of what we call risk management and risk tolerance. And I think without getting too many details here, I think what public health authorities and governments across the country are now recognizing is that there is this balance between sort of focusing solely on COVID-19, but also recognizing, as I just mentioned earlier, about unintended consequences and the fact you have to have this balance. The fact is the virus will be around for some time. We don't have a vaccine or effective treatment at the present time, so we only have the measures of physical distancing, good hand hygiene, staying home if you're sick, et cetera, et cetera. And so, how do we manage moving forward with a risk-based approach that will still open up the economy, but then also keep the activity of the virus at, quote, a manageable level? So I think what we're also talking about is that we will, I think in general, accept a certain level of activity and recognize that we will have cases coming forward, but that there will not be a overwhelming outbreak, and we'll be able to manage it within the healthcare system and also with public health in terms of the contact tracing and so on. And that's the way we need to go forward, while also obviously having a less of an impact on all of those other things that we've talked about, the other infectious chronic diseases and other parts of society that obviously we need to also, as they say, open up so that they also are also able to get back to closer to what was the normal before, but we also recognize it won't be the same normal moving forward. And then hopefully in, let's say, several months or a year or so, we'll have those effective treatments and vaccines, and then we can adjust our response to moving forward from there.
Merci, Dr. New. Une dernière question, opérateur?
Merci. La prochaine question est de Sébastien C-François de Radio-Canada. À vous la parole.
Bonjour, Monsieur New.
Good afternoon, Mr. New. A question in French. I would like to understand the main message today. Is it that things are going well? Is it that we need to continue physical distancing measures? What's the message that you have for us today? Answer. I think that the message is that, yes, things are going well in Canada, but we shouldn't set aside all of these efforts that we've made to decrease the spread of the virus. It's summer, everyone wants to go out. There will be more contact, and with every person that goes out, there will be increased potential for contact. But if we maintain these health measures, physical distancing, good hand washing, wearing a mask if physical distancing is impossible, these are all things that will be important. The message is, yes, things are going well, but we need to continue to be cautious with our activities. Follow-up question, Sébastien? Yes, please.
How much of a game changer is the recognition by the WHO that this could be airborne? À quel point ça change la donne?
How does this change things for you that the WHO and the scientific data shows that it might be able to be transmitted airborne and not only with droplets? How does this change things for you? Answer. I'm going to answer in English.
About the WHO and this so-called game changer, I would disagree. I don't think it's a game changer. I think I have a couple of observations before I answer your question directly. Certainly, we've learned a lot about this virus. I think the scientific and public health community around the world have done amazing work. The virus has only been around for about 7 months, and the amount of knowledge we've gained about things like transmission dynamics, what the effects are on the human body, et cetera, and so on, I think have been nothing short of amazing. So that's one observation. what also happens is that when science advances, it's always incremental. And what I think is different in this case is that normally when there's good scientific debate, it's sort of like insider baseball. The scientists, have good debate discussions among themselves. But in this case, it's happening out in the public eye. So I think that's one thing that's different. The other part also is that with I think the tremendous sort of interest and be it pressure on scientists, et cetera, that come up with new information, evidence about the virus. One of the things I've also noticed that in terms of doing studies and publication, the way it's normally been done is that scientists submit the results of a research study through what we call a peer review process in terms of a scientific publication. It goes there to several peers. They analyze it, criticize it, look at the methodology, et cetera, before it finally gets fine-tuned and then put in a the public domain, I would say, in a scientific publication. What we've also seen sometimes now is that sometimes what happens is that the science is now sort of being put on the public through what we call a press release. And so the scientists, including myself, we don't have much to go on. It's out there in public and we're asked to react to it, but it's just as a quote, a press release. We don't have the actual substantive scientific publication with all of the nitty-gritty details, the data, the methods, et cetera, to actually take a close, hard look at. So that's one thing. The issue of the transmission and droplets and so on is not new. I think it's what I think has been recognized by those of us in the scientific public health community for quite some time. So I'm going to try and explain it as much as I can in sort of terms that I think hopefully most of the general public can appreciate. So first of all, we recognize that this virus is the same as many other respiratory infections. And the main mode of transmission is that when people, cough or talk or sing, droplets are transmitted into the air. And most of these droplets are quite large and have a lot of virus, but they usually fall to the ground within a sort of a few feet, or in most cases, certainly within 2 meters of an individual who coughs or sings or talks, who has a COVID-19 infection. However, it's certainly true, and the science has shown that there are smaller droplets. And so it's more of a gradient, not sort of a black and white, there's large droplets and then there's something called airborne. And I'll get to airborne in a second. But there are also these very small droplets that some of them also will fall to the ground within a certain distance, probably a greater distance than the larger droplets. And there are others what we call in terms of infection prevention control, aerosols. And those also, I think, have a certain sort of a meaning within the infectious disease prevention control world. What I think is a bit misleading, I think, for the general public is that the word airborne means certain things to maybe the general public. It's somewhere in the air. But for those of us working in sort of medicine and public health, airborne has a very specific meaning. An airborne disease is usually a very infectious disease in which, quote, the particles or the virus in this case can linger in the air for several hours and days, and then people can become infected. Let's say someone who actually had the virus and the disease left the room, and several hours later, someone also came into that room and then breathed in the same air, they could also get infected. From the evidence, what we've seen from the epidemiology and so on, to this point, there's no evidence that COVID-19 is airborne. The classic example of an airborne disease is measles. And the R naught for that, the reproductive number, is somewhere in the neighborhood of 18, which means that if someone has measles, on average, they could be expected to infect up to about 18 or so. Hasn't proven to be the case in terms of COVID-19. Influenza has an R naught of about 1, 2 specific situations. The early evidence for COVID-19, I saw an R naught of somewhere about 2. I think based on more evidence and the epidemiology as it's evolved around the world, I would say it's probably now maybe 3, 4, maybe in the range of 5, but it's certainly not in the range of measles and 18. So Let's be clear, the evidence so far has not shown it to be airborne in that classic definition sense as measles. And certainly, based on what we've done so far in terms of the public health measures, they've been proven effective. We've done a good job in Canada in terms of decreasing in transmission with all of the measures we've put in place, the physical distancing, the good hand hygiene, the mask wearing. And that's all been consistent with what we understand about how the COVID-19 is transmitted, primarily by close contact and droplets. And so in English, we've talked about the 3 C's: avoid indoor close spaces with bad ventilation, avoid crowded places, and avoid close contact. And by doing all those things, certainly based on the epidemiology and the way the COVID-19 has sort of manifested itself, certainly we're quite comfortable with the measures we put in place and continuing with that.
Merci beaucoup, Dr. New. C'est ce qui met fin à la conférence de presse pour aujourd'hui.
This concludes today's press conference. Thank you.